This is the Etiology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients. If you've ever had a client who has been through multiple treatments, tried countless medications, if they've received diagnosis after diagnosis from bipolar to borderline to depression to an eating disorder, if their treatment team is confused, unable to find a path that sticks, it might be a dissociative disorder. Many people with dissociative identity disorder go years, even decades, cycling through the mental health system without a clear understanding of what's actually going on. In a previous episode with Annie Goldsmith, we discussed how DID is far more common and less dramatic than how it's often portrayed. In this episode, Monica Ostroff takes us deeper into this topic, sharing her own experience of being diagnosed with DID, then known as multiple personality disorder, in the early 90s. This was a time when the False Memory Syndrome Foundation had just been established and was questioning the validity of repressed memories of severe abuse, which were uncovered in therapy. Monica also reflects on the harmful effects of media portrayals that depict people with DID as either fantastical or violent, representations that are dehumanizing, disempowering, and most importantly, out of touch with the lived experience of real people with this condition. As an accomplished professional, Monica began sharing her story publicly in an effort to break these misconceptions and show what it actually means to live with DID. Through conversations like this, we hope to move closer to a world in which people with DID are met with respect, both for what they've been through and also for their strength, creativity, and humanity. Monica is the executive director of the Multi-Service Eating Disorder Association, META. Prior to leading META, she directed several residential, partial hospital, and intensive outpatient eating disorder programs, in addition to having owned a thriving private practice. Monica is the co-author of Anorexia Nervosa, A Guide to Recovery, and a contributing author to Self-Harm Behavior and Eating Disorders. With more than 25 years of experience in the field of eating disorders, Monica has presented at many national conferences, taught at the university level, and appeared on many media broadcast publications and podcasts. Practicing from a trauma-informed social justice and staunchly Hays-aligned lens, Monica is a dedicated ally and strong advocate working to ensure access to equitable, compassionate, and affirming care for all. Her passion for treating eating disorders and mentoring other professionals was born out of her own struggle with severe and enduring anorexia and life experiences. Hi, Monica. Thanks for joining me today.
Thank you so much for having me. It's great to be here.
Yeah. Can you start by telling me a little bit about what you do in the eating disorder professional world?
I can actually. So I've been involved in the eating disorders field actually way back since 1990 when I was an advocate, but also still heavily engaged in my own struggle at that point, and
Mm-hmm.
entered the field as a professional in 2000
Mm-hmm.
when I was actually running a residential program at Hampstead Hospital in New Hampshire. But today I lead META, the Multi-Service Eating Disorders Association, which is just outside of Boston. And we are getting ready for our big conference in May.
Very cool. So you wanted to talk today about dissociative identity disorder and where it is in the field and in your personal experience as a survivor. Can you tell me a little bit about some of the common conversations that are going on in the eating disorder field, or maybe more broadly speaking, in
About
the mental health about DID that makes it feel so important to talk about?
Yeah, I mean, I think it's one of the most heavily stigmatized disorders, and we probably
Mhm.
can thank popular media for that. You know, it tends to
Yeah.
portray people with DID as being really theatrical and quote unquote fascinating, and
Mhm.
everybody has some sort of like internal serial killer living in them. The media has
Mhm.
really just made this such a fantastical kind of disorder, but it's also created a tremendous amount of fear and stigma for folks who do have DID.
Yeah.
And so there's that piece of it. But I also want to acknowledge that, certainly in graduate school, I feel like most of us are not even remotely trained in recognizing DID. I remember spending a lot of time learning about the various presentations of schizophrenia, for example. And
Yeah.
we got to dissociative disorders and DID in particular. Back then it was called multiple personality disorder, but the professors would just sort of say, oh, it's so rare, you'll never see it, don't worry about it. And that literally was the extent of what, we learned about when it came to DID in school.
Yeah.
And yet DID is actually more prevalent than schizophrenia and bipolar disorder combined. But we don't know how to recognize it or how to treat it. And if we are moving through the world believing that DID is what we see in the movies, we will never spot it.
Yeah.
94% of people who are DID systems are covert. And then OSDD, which is very similar to DID, or OSDD1 is very similar to DID, is even more prevalent.
Yeah. When you were in grad school learning about DID as something you will never encounter, had you been diagnosed yet?
Yeah, actually, I was diagnosed in 1993, I believe it was. So it was actually still called multiple personality disorder back then. It was going to change to DID a year later. Back in the 90s, that came with its own challenges because that was actually when the False Memory Syndrome Foundation was quite a thing, we shall say. And so many therapists and psychiatrists as well, were really terrified about losing their licenses because that foundation, along with just this large movement to deny the existence of MPD or DID as legitimate, or even the prevalence of that pervasive type of childhood abuse and sexual assault, it was just kind of crazy. So getting treatment in the 90s was, from my perspective, an impossibility. It was very rare that people would get good treatment and move forward. So it was sort of like, you have this thing, good luck.
Wow. So it wasn't just that people don't know about it, it was that the lack of knowledge was created almost as a conscious reaction to what was assumed to be false memories and the reluctance to accept memories that came up in therapy.
Yeah.
Especially as a product of hypnosis.
Yeah, there was also, this idea that came out of the False Memory Syndrome Foundation, which, if you kind of dig into that, the history of it is remarkably concerning and looks like there was some ulterior motives for the design of that particular foundation. It's actually pretty scary. But the allegations were that therapists and psychiatrists were implanting these memories in people and that the memories weren't real. What is, I think, probably true and really interesting is Bethany Brand, who is somebody who does a lot of research on DID today and has actually designed and developed some really wonderful treatments for it. She has a study going on right now. In fact, when asked, she typically says, I think people deny the existence of DID because it's very hard for people to understand that that level of abuse and torture happens to children. And that as a society, we sort of are either turning away from it or allowing it to happen. And in some ways, we can be complicit by not doing more about the childhood abuse. And it's really difficult to see the level of damage that pervasive type of abuse can do to a human.
Yeah, it's a painful reality to acknowledge.
Yeah, it's hard to sit with, right? Whether you're the person who has gone through that type of abuse or you're somebody treating it or sort of viewing it from afar. It's really difficult.
Yeah, and I imagine especially for people who are close to, and I don't know if you've experienced this, but people who are close to the person who's abused and maybe know some of the people who were involved or perpetrators of that abuse, like just to hold that as a reality.
Yeah. Yeah, it's really challenging.
You were diagnosed in the 90s when this whole false memory syndrome was going around. Can you tell me about what that process of getting diagnosed looked like for you? Anything that led up to that?
It it the 90s for me were a gigantic mess. I spent pretty much the decade hospitalized. So between having a really severe eating disorder and then, of course, having DID, my 90s looked really chaotic until the very end of them. So I don't know that I would have been diagnosed with DID had I not been hospitalized in a straight psychiatric unit. So while I've had specialized care for eating disorders, I don't think anybody there was ever going to recognize that the resistance of my eating disorder to treatment was actually born out of DID itself. So going into a psych unit, even that was challenging. You know, people with DID, it takes an average of anywhere from 6 to 12 years to get a diagnosis. So most people are really struggling for a long time. I think in some ways I'm not going to say lucky because I actually didn't get treatment for it once I got diagnosed. But after going through a multitude of diagnoses and many, many treatments that didn't work for depression and anxiety, I had this laundry list of diagnoses that didn't really make any sense. Right. So I used to joke at one point, like maybe I'll put these in alphabetical order and create some kind of song about them because it was just this really lengthy list. But I do have a couple of parts in my personal system that present as overt. And there was also back in the 90s a bit of chaos in my life because of some parts of my system. And I, would hear these stories about things that I had done that I was like, I would never do that, but it turns out, in fact, I had at that time. If you take all of those things that I just kind of rambled on about and throw them together, people in the psych unit that I was kind of repetitively hospitalized in for a couple of years actually began to see and realize that, okay, this is not this laundry list of diagnoses. She actually has MPD.
Yeah.
And so it was more like you'd start seeing it come out on the paperwork than anybody really taking time to talk about how to cope with it.
So you had been hospitalized for close to a decade.
Yeah.
Um, a whole bunch of different diagnoses, which is I want to say pretty common in flawed diagnostic system. And there were inconsistencies in those diagnoses and also inconsistencies in the ways that you were presenting that led people to believe like, okay, this is multiple personalities or DID.
Yeah, I absolutely have a part of my system that you can't miss. So like initially that is not a part that is ever public, but when you're hospitalized for a long period of time, at some point that part's going to show up. And it did. And I think that was the part that sort of made people really kind of go, oh. But, I wonder how long it would have taken to actually get that diagnosis if I didn't have a couple of overt parts in my own system.
Yeah.
Because the idea is it's designed to be covert, right? It's designed to protect the person who's suffering from the abuse. It's also designed to hide it from the external world.
Yeah.
And it's designed to be protective against your perpetrators as well. So the really DID is just kind of this creative and brilliant solution that the brain comes up with to survive some things that are pretty unspeakable.
Yeah. Is it okay for me to ask about your parts and what was showing up then, what's showing up now when you talk about more overt parts and some that are more covert?
Yeah, I actually don't share much about the different parts of my system.
Okay.
To me, for me, it doesn't feel particularly safe to do that.
That makes sense. Yeah.
Because I am somebody that I have not fused. Like I still do have an active system, but my system is very cooperative and we work together to do things like lead meta. I've had a really successful career. So I think part of my message to people is don't doubt people's ability. Like this diagnosis has actually not impeded my ability to have a very successful career and help many people recover, design and lead many programs. So I've been in the field for a long time now. And this is something that most people never knew about me. Like unless you live with me, you can't tell.
Wow.
So I don't think.
Yeah.
Yeah. So
Mhm.
it's important,
Yeah.
I think, for people to understand that you can have what we call it functional multiplicity, which is a system of parts that work together. And
Yeah.
different parts have different, like I can speak about my system in more generic ways, but like
Mhm.
sharing things like specific names and ages doesn't feel
That makes
helpful
sense.
to me or to other folks. But,
Mhm.
essentially, like I have different parts that work together to complete my
Mhm.
job. And it's
Yeah.
always been that way. I have different parts that have skill sets that I actually can't access unless they're present.
Mhm.
Can't even retrieve the information unless they're present. Um, but at this point in kind of where I am, being able to call forward those parts is much easier.
Mhm.
Historically, you'd kind of be, I'm trying to think of the wording that I want to use. It almost felt a little bit whimsical. It wasn't. I mean, any system has
Mhm.
its own way of being, but sometimes if there was something that happened that was triggering, I might not even be able to access my demographic information. I might only be able to call up, an address that I had years ago, which is a clue to what part would be present, right? Like, so how old are you? And it's like, I don't know. And I legitimately didn't have access to that information because there's a different part present. So
Wow.
but these days, there's a big cooperation between parts. I have a huge, big hearted compassion for my younger parts. They bring a lot of playfulness to life, a lot of creativity to life. Have been responsible too sometimes for giving ideas to sort of the more professional parts of the system for designing and developing activities when I was working in residential levels of care, partial hospital levels of care that would be therapeutic for clients, for example.
Mhm.
So but there are things that happen. I was talking about being triggered, for example, and I can't remember my demographic information. Somebody with DID can have, and I've experienced this in my history of being triggered by something, not necessarily understanding what the trigger even was. And,
Mhm.
I've learned to ski when I was a kid. I love to ski, but
Yeah.
I remember this one time where I was really triggered by something, and I was, getting off the ski lift and heading down a regular old blue trail that I'd skied forever. And it was the worst I've ever skied. And it was because parts that knew how to ski weren't around, and it was crazy. So I
Wow.
realized that I was skiing very much. So a level of co-consciousness, but realizing that there was a much younger part that had been triggered that was
Mhm.
kind of blended, and that's something that can happen that makes people appear a little bit, maybe a little different than they
Mhm.
typically will. But I think when we see that in clinical settings, sometimes it gets labeled as borderline personality disorder or attention seeking behavior. I'm not saying that we would see someone on a mountain, but like my personal experience was, oh my God, I need a part that knows how to ski, right? Like this is not safe. And if you just sort of take that skiing scenario and put it in a clinical setting, unfortunately, we tend to label behaviors like that or situations like that as attention seeking, when in fact it's just a dissociative experience that's
Mhm.
happening.
Yeah. And like we know to some extent everybody has where something from the past will get triggered and suddenly different emotional states that maybe we didn't even know are there are activated. And for you, it feels like it was much more than that. It was almost like a different person or a different part of you was activated or part of you from a different time in your life.
Yeah. Yeah. It's interesting because sometimes like I no longer, well, I don't have like big bouts of amnesia
Mhm.
necessarily, but so people will give you experiences of like, oh, I came back and I had no idea what was going on. That's one presentation that some folks will have, but you can have this other
Yeah.
presentation where you're quite aware of where you are and what you're doing, but you
Mhm.
feel very confused. It's like, why can't I remember how to ski? Why can't I remember where I live, and why can't I remember how old I am, and why like
Yeah.
I just can't access information. And that
Mhm.
is a cue for people who have DID or OSDD to check around inside to sort of ask like, who's here? somebody else is in the front with me. I am not alone here. And
Yeah.
that part has come so far forward that it has some control over like the physical body and the information that's accessible.
Mm-hmm.
And when you know who that is, you can literally have internal conversations with that part to either, sort
Mm-hmm.
of calm it down, reassure it that everything is safe and
Yeah.
okay, what day and year it is, if you can pull that up. And you can also ask for other parts of your system to come forward and assist in whatever is going on with the part that's triggered.
Mm-hmm.
So like whoever is good at taking care of a younger part who seems to be present right now, can you come forward and do that because I can't manage this right now? Or, another example is just whoever knows how to ski, now's a good time for you to show up.
Yeah.
Like if I know somebody's a good skier in here.
What I hear you describing, and this makes me think of internal family systems, but it feels like as you're talking, like you've gotten access to a self that is able to hold and get to know all the different parts.
It does not feel that way. So, the part of me that's with you right now has
Hmm.
access to a lot.
Yeah.
And I'm not always the part that is in the front, you know?
Mhm.
So it's much more fluid. Like I love IFS. I use it a lot with my own clients, and
Mhm.
I love how mainstream it has made parts, but
Yeah.
it's a different. Okay, let me give you an analogy because I think this might be
Yeah.
helpful for people. And it's actually one that I gave to somebody recently. So when I think about IFS and the parts that Dick Schwartz talks about, I think about a very long table. Maybe it's like an executive meeting table, or maybe it's a dining room table, right? And all the parts are sitting around it. In fact, there's even the dining room table like strategy, right? Or intervention that you can
Mhm.
use with parts to have them all talk together. They can all see each other. They can converse with relative ease. And we
Mhm.
even talk to people, right? We're like, invite that part forward and it shows up, and it's very fluid in how it works, and everybody knows about each other. So
Mhm.
DID, there isn't a table. There's a hallway with rooms and all the doors are shut.
Wow.
And so you have to figure out how to get the doors open and how to introduce everybody to each other, because in the beginning, nobody knows anybody else is around.
Mhm.
But they're all, one person might come out of their room and do whatever it is that they do. And then they go back in their room, and then somebody else leaves their room, opens the door, leaves their room. And they, don't necessarily know there's anyone else in those rooms. Might not even notice that they're in a hallway as they're going to do whatever it is that they're going to do. So it's a really different experience than what we talk about with parts. And sometimes with IFS, the challenge with IFS and DID is that where Dick Schwartz has taught us for years to get people into the, self with the capital S and all of the wonderful, fabulous C's of courage and compassion and all of that stuff, there isn't necessarily one self.
Mhm.
You can have several selves and several fragmented parts. And it's not necessarily about finding one part that can be quote unquote in charge, as there is in the IFS model.
Mhm.
And parts of a DID system are set up a little bit differently than the structure that he's set up with managers, the firefighters and protectors, and then the exiles. There are different roles that people will play in a DID or OSDD system.
Yeah. So when you talk about that hallway with all the parts and their doors behind, is that parts are in hiding more often or afraid to come out and come out only when they're called to by whatever the situation or
In a way, like, thank God it works that way, because if they were all coming out whenever, you never would have survived the abuse that you survived, right? So if I think about my history, and I didn't know that I had DID as a kid, and looking back on it, it's like, oh, that makes sense now. I can see all of the symptoms and the signs that were there that said that I did have it then. But when
yeah.
I think about how it functions, right? Needing to be able to go to school and be in school to be able to focus, make friends, do the work. There was a part that could do that. And it didn't have access to the stuff that happened the night before or even the morning of. Thank God because there's no way I would have survived. If
Oh,
those parts started coming out, though, the amount of chaos that would have happened, I never would have had any friends. I never would have made it through school. And I don't know that I would be on the planet today without this disorder, frankly. Um,
wow.
yeah. And similarly, there were a lot of different, in many ways, my story of trauma is pretty overwhelming because there were so many people involved and it was so pervasive for so long.
Yeah.
If the parts that were managing each aspect of that were ever present, the chaos and overwhelm would be so great that I like literally I never would have survived. There's no possible way. So
Mm-hmm.
I'm in many ways I'm really grateful to those parts. Like I don't personally hold necessarily the feelings and I have the
Mm-hmm.
chronological most of the chronological
Yeah.
events in memory, but I'm not, personally attached to it. Somebody else holds that and
Yeah.
continues to.
Yeah.
Um,
So these parts of you learn to go behind the door or like lock themselves in the room so that other parts of you could function in day-to-day life.
yeah. And so each part generally has some type of job available. So for people who don't understand some of the parts, I'll just give you a couple of ideas. So there can be parts that are really good at socializing and making friends. And
Mm-hmm.
so there are environmental cues for those parts to come out, walking up the stairs of a school bus, for example. Great
Yeah.
time for that part to come out because you're going to be sitting down with other kids. So if you are a child, or, as an adult, going out to a restaurant and meeting friends, the parts that manage social aspects will just come forward because there's the environmental trigger to come forward. Um, Parenting, right? Really great caretaker parts typically exist inside a DID system. There has to be because there have to be parts that can manage younger parts. So there
Mm-hmm.
are some really beautiful parts that are amazing at doing things like parenting, taking care of little kids, and being around children call those parts forward just automatically. So sometimes I think about a system almost as like a series of gears that just kind of shift and change and move together and very fluidly depending on what's in front of them. So
Mm-hmm.
it breaks down at some point, right? Because at some point, hopefully, you are able to extricate yourself, free yourself from abuse and torment
Mm-hmm.
that you're living in for a different type of life. And then the parts kind of don't really know what to do because
Mm-hmm.
they don't have like their job is kind of gone.
Yeah.
They don't need the part to come forward and manage the abuse. And for like sometimes when you see things like self-injury or self-abuse or these really critical internal voices in a DID or OSDD system, those can be they're called persecutor parts. And they
Mm-hmm.
tend to folks who can work with DID systems or are friends with DID systems can be afraid of those parts because they feel really dangerous. They feel really self-destructive. But a lot of times when you dig down underneath, what you find out about those parts is that they're there to train the person to survive the ongoing abuse. They're trying their best to make sure that you will be strong enough to withstand whatever is coming at you that night or the next morning or during the day. We can probably agree that might not be the best way to go about things. But when you have been doing this since you were 1 years old or 2 years old, or 3 years old, your system just kind of figures out how to survive. And that carries on into adulthood. And you can see some really serious self injury that,
Mm-hmm.
in addition to sometimes obvious dissociation, not necessarily indicative of DID, but you can see the person's sort of dissociative states. And then the task that we have, right, is to really kind of get to know that persecutor part and find out what it's doing, what it holds, who it's trying to basically train to withstand this horrific abuse and give
Mm-hmm.
it a new job. It's not that different than IFS, right? Like we're always
Yeah.
looking for how do we take these parts that are doing things that are well intended, but don't really work very well for physical health and well-being or mental health and well-being. And what other job can we give them? The place where that does not hold true, though, are for people who are RAMCOA survivors. So ritual abuse, mind control, organized abuse, like they have parts that are actually programmed inside to self-destruct. And that is not the same thing at all as trying to help a system survive abuse. That's a very different thing.
Mhm.
So in the event anybody's listening who is a Ramcoa survivor, I just wanted to make sure that folks know that there is a difference there. And I just want to respect their experience, which is different than my own.
Yeah. And meaning that in that case, because those parts are programmed by the abusers, they may not have as much of a protective function.
Correct. Like their function is entirely to protect the abuser and to have the person self-destruct.
Wow. So you went sometime or like a significant part of your life without a diagnosis.
Yeah.
What was the experience like for you having all these different parts, but no framework for understanding what they were?
Well, honestly, I thought everybody was built like I was internally. Like I had no
Yeah.
idea that people didn't experience things the way that I did. I when you think about it, we don't really necessarily, I don't know, we don't have a framework for what somebody else inside somebody else's head looks like. So I would
Yeah.
hear what people would say and kind of apply it to my experience, thinking everyone had it. But,
Mm.
I realized that once I had the diagnosis, looking back on it, it explained a level of confusion that I experienced. So I would have these times in school. I've always been a good student. I have a part that's at least one part that's really good at academics and enjoys it. Thankfully, that helped
Yeah.
a lot, and probably also helped me fly under the radar. But every now and then, I would have these experiences, whether it was in school or, in a circle of friends where it's the experience is almost like kind of getting sucked backwards a little bit. And all of a sudden, there are these things that are just like coming out of your mouth. And you're like, oh my God, stop talking. Like you want to pull the words back because they're not things that you would ever say. And it's another part that has just gotten control of saying something. I think it's really hard for people to understand what that experience is like if you've never had it, because in a way you could envision, I think the more I need a word that is a nicer word than the one that's in my head, but people are sometimes get suspicious, right? And are like, oh, is that just an excuse for not being accountable for bad behavior? When in fact, it's just a dissociative experience happening and you need more internal communication and internal cooperation and collaboration so that stuff doesn't happen. But I mean, I remember this really benign experience, but it was so baffling to me. I was in 8th grade at the time. And for whatever, they start the day with the Pledge of Allegiance kind of thing. And um, for whatever reason, I could not stand up. Like I still really vividly remember this. Like I couldn't stand up. And I'm not helping the teacher like me very much that day. And I was generally well liked in school, but while he's trying to get me to stand up to say the Pledge of Allegiance along with everybody else, out of my mouth comes some excuse for why I can't stand up that was an absolute, like, it was not true at all. Everyone in the room knew it. And I felt like I was backwards, kind of watching this happen and was horrified because
Oh.
I was not known to be a quote unquote liar. I was
Hmm.
so baffled. And I think everyone was baffled because it was so
Yeah.
wildly out of character for me. And
Hmm.
it like I that was one of the things that I remember thinking about from time to time, which was benign, but I was like, am I insane? Like what just happened? I don't understand what just happened. And typically I think maybe those things, similar things were happening, but I was not fully present for it. That's when I would have moments of amnesia. So I would have people tell me stories of things and I would be like, that wasn't me. Like their memory's terrible. That was somebody else. Or I'd get like accused of something, right, that I wouldn't do. Like then I would deny it because this part didn't do it, but another part did. And so I was completely confused as to, I felt like so many people would, like tons of people, but here and there, it would feel like people are gaslighting me, accusing me of doing things I didn't do, accusing me of being a liar. So, by the time I was in my 20s and got this diagnosis, I could look back and kind of go, oh, that
That's
explains a lot of confusion. right? It explains, it even explains the shifts in mood that would happen. I think sometimes you can look like a really good actor when you have DID because you can have a rapid internal shift where you go from being extremely upset about something to being completely fine. And you can feel like not everyone experiences this, but personally, if I'm going to be co-conscious for something, I can literally feel what is like almost a somatic click internally and a complete shift in outlook, perspective, mood. So I don't lose time for that anymore. But yeah, it's in a way, it's such a difficult thing to explain because I think people hear even what I'm saying now and must be thinking like, ah, she's a mess. Like, how does she function at all? And yet, when all the parts are working together, I function great. If I'm training or presenting, there's two parts that work together to do that, and they do a great job. If there's, something like going out and hanging out with the dog that you can probably see back there, there's parts that are great at that. And when you're working together as a series of like sort of gears that move in and out as needed, it's a perfectly healthy, fine way to live and to be. It's when they're not working together and they're all coming out all over the place because they either the situation has shifted and they don't know when they're supposed to come out anymore because your life looks different, or it's been identified and you have a therapist who is saying, I want to get to know these different parts. And then all of a sudden, everybody has an opportunity to be able to come forward and express themselves. It can get really chaotic. But otherwise, well, okay.
Yeah.
I should probably also just put in the little caveat. I also recognize that I am a very high functioning system and not everyone is. So there are people with this diagnosis that are really, really, really disabled by it. I think part of and I have so much compassion for them being in that space for long periods of time. But I think part of what, kind of lights that internal fire for me is that there are also a lot of high functioning systems. So when I went to a conference that is actually focused on DID and they have a section for mental health professionals with the diagnosis, there are a lot of us out there with this diagnosis who are therapists, psychiatrists, doctors, lawyers. Like there's so many people who are high functioning with this disorder. In the eating disorder field, though, I think part of the reason why I was sick for so long is because my DID didn't get treated. And 40% of people with DID have eating disorders. We already know, right? Like about 90% of people with eating disorders have a trauma history. And around 50-ish percent of them, probably more, meet criteria for PTSD. These people are in our practices every day. And rather than making somebody, not making, it's terrible wording there that I'm just using, but rather than having somebody suffer for decades with an eating disorder that feels confusing and resistant, screening them for complex dissociation makes sense because there are papers back. If you actually just Google, you will find research back in the early 90s about the level of DID that was present in people that were not getting better. There's literal journal articles in the International Journal of Eating Disorders, for example. There's a bunch that I actually list in a couple of trainings that I've given. And different parts of a system can have different eating disorders, which is part of how it gets really challenging sometimes. So you can have a part that's really heavily restricting and that's its only behavior. You can have another part of the system that's binging and purging, another part that's over exercising. There can be a lot of different things happening within the system. And that inconsistent presentation of somebody coming into therapy, right? And everything's great with food this week. And then the next week, it's like a disaster. And a week later, something else might be going on, or a month later, something else is going on. It's really common.
So you might have different parts of you that are showing up to therapy different times or to treatment different times. And you might have parts that respond differently to treatment as well.
Yes. Yep. And the one thing that can also happen is you can have the same part presenting for treatment, right? So like one flag that dissociation might be happening is you have one part coming to treatment and everything is looking like it's going well. You're understanding each other. You have goals. You've agreed upon the goals. And the person goes out and it like is a complete disaster for them during the week. And you're sort of like, I don't understand what fell apart because we had this discussion and we had these goals. We even had a strategy. But if that part is only presenting for therapy and isn't present to carry through or isn't the part that has the issue, then it can't carry through with the therapeutic recommendations. So you can get a lot of what looks like treatment resistance or what looks like a different diagnosis that is actually DID. So once you gain the trust of the person and you start to gain the trust of the other parts, you'll start seeing other parts presenting in session.
Mm-hmm. And those opportunities to build trust, is that when those parts show up, how you respond to them? Or is it something, what is letting those parts know that they can trust and they can come in?
A couple of things. I think overt statements by the therapist are really important, right? Like all parts are welcome here. There's a couple of different theories. There's one theory that really talks a lot about that I vehemently disagree with, but I'm opinionated. That basically says, oh, only an adult part can show up in therapy, and the same part needs to come, and then everybody else needs to talk through that part. That actually doesn't work because you don't have co-consciousness with all of your parts. And you don't have co-consciousness with all of your parts for a reason. So whenever therapists get into this, like only an adult can show up in session, you actually are putting up a roadblock for therapy to progress forward. You can have safety measures, right? Like in place that say, I'm willing to talk to anybody. I would love to talk to any part that shows up in session. I want to get to know everyone. I want to hear what everyone has to say. Granted, I can only hear one part at a time, right? Because otherwise there's chaos. So we're going to have to take turns here, but you're welcome here. And to really work hard on not being judgmental and being open to whatever shows up in front of you. But you need to have guidelines, parameters, and guardrails around that, right? Like there can't be any violence in the therapy room. You can say that, parts can show up and can be angry, but I don't tolerate yelling. So there's going to need to be a level of emotion regulation that happens. And I'm happy to help you do that. But I don't want anything thrown in the room, for example. And if there are child parts that show up, we need to have an adult that at least knows how to get you safely home, that you know how to drive home, or you need to have somebody bringing you if you're coming in person. So making sure that there's safety around. But realistically, most systems know how to be safe. We've gotten this far in life.
I have so many questions. So, okay. There's like your experience of having an eating disorder, being in treatment for so long, finally getting diagnosed in a time when false memory syndrome was pretty hot, or so there's, and the story of how you've got into a place of collaboration between your parts, and alongside that there's the story of, I've been told, or people believe, that I can't function if I have this, and your story of being able to share publicly, and also some of the fear that I still hear is present now, that if people know what my internal world looks like, they'll start to question all the things I've done.
Well, I mean, I don't know that I think people will question the things that I've done, because I think at least my career speaks for itself. It's, you can't take away people that I've helped recover, right? I mean, I haven't done the recovery. Our clients heal themselves, but we're hopefully a good guide for them. People can't deny that I've designed solidly good programs. Like that speaks for itself. There's plenty of things that I've written that, like that, the stuff that's happened is very concrete. So nobody can say that I'm not capable of doing those things. Those things exist. I think part of the reason that I'm so sort of passionate about, it feels like suddenly speaking out because I've been living with this forever, right, is that it's heartbreaking to me to see what's happening to a couple of things, I guess. So one, people are losing their jobs. when they're coming out with the fact that they have DID. So people will say, there was a person that shared on a community board at a conference once that she had been working at a business for 20 years and had been given regular promotions, was well respected, like very clearly did a beautiful job. And in her 20th year at this place, decided to be vulnerable and share her diagnosis because someone else had shared a different diagnosis and she thought it was safe. And she ended up getting fired.
For her diagnosis, or for acknowledging her diagnosis.
Yeah.
Wow.
Because then, the person thought, I mean, that's technically supposed to be illegal, right? But there's also ways that people can figure out how to do that. That should not be happening to people. There's that reason. There's also the reason that more and more and more I'm coming into conversations with other professionals in the mental health field who are struggling remarkably with aspects of their own mental health and feel like because they're providers, we can't talk about it, right? Like somehow we're supposed to have all of our crap together, so to speak.
Yeah.
And the reality is, like, we're humans, right? Of course, we're going to struggle with mental health issues. There are therapists who have bipolar disorder, schizophrenia, DID, PTSD, depression, anxiety, eating disorders, blah, 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 right? We never seem to talk about it. I mean, I can't tell you how unbelievably affirmed I felt when the first year I went to this conference that's focused on DID, I did it virtually. And I noticed that they had this lunch session, which was a Zoom session for mental health professionals that had DID. And I was like, oh, wow, I'm just going to log in. And I expected there, because I'm so naive, I expected there to not, even though I know statistics, didn't expect there to be that many people. There were screens of people, like screens of Zoom people, 25 on a screen, right? There are a lot of us out there. And at some point, we have to start breaking the stigma and making it okay for mental health professionals to talk about what they're dealing with also. I'm not talking about having those conversations with our clients, of course not, but with each other. It should be okay to be in a conference and acknowledge something from your lived experience. And I don't think we're there yet. And then there are the people that I worry so much about. So I did a talk last year at the Meta conference with Rachel Milner, where I acknowledged my diagnosis. And we talked a lot about, sort of signs and symptoms that you might see, the fact that DID exists. There are people who believe it doesn't. It absolutely exists.
Yeah.
And how can we recognize that? And since that talk, I've heard from 4 different professionals who realized that people that they had in their practice who had been struggling for over 20 years with their eating disorder had either DID or OSDD. And now that they're getting treatment, they're actually starting to make progress. So my question, right, is like, how many people with SEED actually have DID or OSDD and are not getting treatment from that? I know, yes, there are other presentations of SEED, but I do think we have quite a few people in our client community that are getting missed because we all think DID looks like something different.
Yeah. So you've built up enough in your career that it feels like to some degree gives you some immunity to the stigma, or like people can see for themselves what you've accomplished, and you feel strongly about talking about it because some people don't have that.
Yeah. I think when you have a position of relative safety, and I wasn't sure that I did have relative safety. I mean, I'm not going to say it's kind of silly when I think about it, because when I think about Meta as an organization, it's such an open, accepting, loving organization that really promotes protection of people with intersecting identities and really works hard for access to equitable care, that type of thing. It would be really ironic if they fired me for having DID, right? But there's decades of stigma. I mean, I've gone through my entire career feeling like a giant imposter, like, oh my God, if people only knew, and like terrified sometimes when things would happen that are benign, but out of character, right? Like, oh God, somebody's going to find out. Why do we have to live like that? Can we really be accepting and open to people's different lived experiences and learn from each other and help each other really thrive on this planet instead of being so judgy about what somebody might be dealing with? So the other thing I just wanted to clarify is I don't share like sort of like names and parts of my system publicly, at least not at this point, because I think a couple of reasons. My system's really good at masking. So, the idea is for people not to be able to know who's present. I'm not sure how I feel about, sort of more overtly or really younger parts being able to potentially be triggered out by somebody. Would that happen? Probably not, but I don't feel comfortable enough, to
Yeah.
share that.
Is that like it feels almost like a betrayal of those parts that want to be um I don't know if unseen is the right word, but how would you describe it?
Well, I think some of them I think would be some of them I think would be very happy to be seen. But the reality is that there are some really unkind people out there in the
Yeah.
world, right? Like you
Yeah.
might be somebody who is a really loving, trustworthy, open person who's
Mm.
curious and might genuinely want to know. Somebody else might listen and hear something that they think sounds fascinating or entertaining and
Mhm.
talk about that part of my system in a way that's really denigrating,
Yeah.
that's just unkind, mean
That
spirited,
makes yeah.
and use it as, potentially a way of discrediting other parts of my system that function quite well in the professional space. So
Yeah.
I prefer not to give people ammunition.
That makes sense. That feels to me, I work with people with psychosis, and I've heard something similar from people, and I know totally different, like symptoms and underlying presentation, but sort of sharing and feeling like the person was not even like overtly judgy, but sort of like, wow, this is like an interesting, almost like watching some like watching an interesting show or something that takes the humanity out of the experience.
Yes. And I think people, when we do that, right, we forget what some of this is born out of.
Yeah.
Like the unspeakable daily trauma,
Hmm.
in my case, before the age of 2, all the way until 36, 37 years old. Like by the time I was an adult, it wasn't every day, but like certainly, throughout my high school years daily, there's a
Hmm.
lot of pain and terror and just horrificness that built this disorder in a way, or this disorder was
Yeah.
built on that. And sort of making fun of something that is born out of that much pain is really inhumane, I
Yeah,
think.
for sure.
And then targeting people who have already been victimized in such horrific ways just feels terrible. So I think there's a place where it's like you just learn to be really careful about who knows and who doesn't. I mean, I shared it with like no one. One of my dearest friends was like, I had no idea. Like one of my dearest adult friends.
Yeah.
For me, it's been more recent being public just because I think we really need to start looking at this and understanding that the numbers are big. I mean, there's like 6% of our patients in partial hospital programs and in outpatient clinics have DID.
Mhm.
5% typically around 5% or so in inpatient settings.
Yeah.
For
Yeah.
there's a lot.
Yeah. Can you leave us off with a few of the indicators, like as a professional working in in this
Yeah.
field, some of the things that we can look out for that would indicate DID, and also how that would shift treatment?
Yeah. So some things to look out for is somebody that comes into treatment or has been in your care and has been through multiple different treatments and nothing seems to work. Lots of different medications that didn't work. I feel like if I gave you a laundry list of all the medications that I'd been tried on back in the day, it was crazy. Nothing worked. You'll see people who have had, ECTs, TMS, all different types of therapies, just nothing seems to be sticking. People
Hmm.
who come with a lot of different diagnoses, like anytime you find yourself going like, I think this person's bipolar and I think this person has borderline personality disorder. I think this person has OCD. This person has an eating disorder. I think this person had,
Yeah.
I think, like, I think this person has depression. Like, and there's this long list of them. Think dissociation. If the treatment team is confused diagnostically, if the treatment team is confused about what to do, I've heard a lot of people who end up being diagnosed with DID say things like, oh, my treatment team always used to say like they weren't really sure what to do with me. Thank
Mm.
DID.
Yeah.
Screen people. I mean, if you're a clinician, the mid is free. It's
Hmm.
like you can literally get it delivered by email into your inbox. It's 217 questions. It is really challenging for a system to take because it's so long and different parts can, sort of weigh in, and you might have to give it more than once, certainly in order to capture more experiences from other parts. But anyway, that's more along the diagnostics. Those are some things to look for sure. Systems mask pretty well in sessions for safety reasons. So you
Yeah.
also want to look for things like continuity. So sometimes, if somebody seems to be having difficulty accessing information or
Mm.
giving you conflicting or just sort of different points of view about the same topic,
Yeah.
that is often different parts of the system. So like both perspectives, I actually have my own podcast called Healing My Parts, and Kathy Brody was just on it in an episode that was released in episode 19. She does a really good job of describing this, right? It's like, you know, it parts have different perspectives because they're going through a situation, and this part was present for the first half, and this other part was present for the second half, where the experience was different. And so
Mm.
this part believes one thing and this part believes the other thing, but both experiences are true. Neither was present for the whole thing. So in session, what you might be seeing is somebody is a part presenting their perspective. And in the same session, or maybe the next session or one after that, hearing the polar opposite, which in your head might make you like raise an eyebrow. That very often is a different part, right? Presenting
Yeah.
parts that seem to be functioning really, really well in their life, or like a client that seems to be functioning really well, but they come in describing like this horrific despair, but you don't actually see it. That's
Mm.
another sort of sign.
Yeah.
There are lots of little things to look for over time, but I think the biggest one for people who have had it for a long time that are missed is this like been in treatment forever, nothing's working.
Yeah, that makes sense. And the discontinuity which you describe, I feel like I've seen that in people that like different presentations at different times, and it feels like there's such a strong divide
Yeah.
between, yeah.
There's
And
fascinating facts. I just learned this like about a year ago. So I always share it because I think that this is a fascinating thing about DID. The so a part can have a problem, and the part that has the problem has to be the part taking the medication or it won't work.
hmm.
Isn't that wild? And you can also have parts that are allergic to something and parts that are not. So like so in our world, right, in the eating disorder world, somebody who says I can't eat X, Y, or Z because it gives me hives or I get sick, but then
Hmm.
is able to eat it at other times. They're not lying. They're different parts eating that
Hmm.
food. One can tolerate it, one can't. And you can actually see parts changing on functional MRIs.
It's interesting. Like when you're describing the psychological component to me, that feels almost intuitive because I feel like I've seen it, and maybe or for sure dissociation comes like on a spectrum where there are gradations of it, but I've definitely seen like someone comes in feeling totally fine, and I can sense that like the thing they were struggling with the last session is still there,
Yeah.
but not accessible in this moment. And in order to treat what's there, we need to be interacting with it. It's pretty interesting to hear you describe how that can play out at such a tangible physical level.
Yeah. It's an interesting, it's really a brilliant way that the brain has figured out how to survive. I also incidentally will ask people to, if they experience internal voices, like a lot of times people won't say anything about the voices that they hear
Yeah.
because they automatically believe they're going to be labeled as psychotic or have schizophrenia, which is a common misdiagnosis for people with
Yeah.
DID. But the voices are very internal, and
Hmm.
communication happens both through those like sort of heard voices, but also through really strong sort of urges or visual pictures. So you can have parts that will just give you almost like a slideshow of what's going on. So knowing to ask those kind of questions about how people get information
Hmm. Yeah.
is super helpful.
Yeah. It's interesting for me to hear. As I'm hearing you talking, I'm thinking about clients I work with psychosis who like, and it does feel similar. And I know with the hearing
Yeah.
voices work, if you're familiar with that, there's a lot of people talking through some of the experience of voices in a less pathological way, and
Yeah.
that gives them more meaning than just brain chemistry.
I can't recall the actual category now, but if you look on the multidimensional index of dissociation, it's like Paul Dell wrote it. That's the one that you can get for free to use like literally diagnostically. They have, is it Schneider's first rank symptoms? They overlap absolutely with DID.
Yeah. And I'll put a link to all of these in the show notes. Anything that you feel like would be helpful for people to have, you can send to me as well.
Oh, sure. That would be great. I
Yeah.
definitely will send you some. I think
What?
for people who are also interested in learning more, like Dr. Mike Lloyd from the UK has a CTED clinic channel on YouTube, and he puts out a lot of really great educational stuff that's so relevant for therapists
Mhm.
in particular. And then I have a lot of mostly interviews on my podcast, which is Healing My Parts.
Yeah. Okay. I'll put a link to that as well. What do you want to leave us off to? Professionals who might be listening and working with people with DID or people who have DID and are hearing this.
Yeah, to if you are somebody that has believed that either DID doesn't exist or that it only presents in this sort of fantastical way and that it's so obvious, to please be open to the fact that you have people sitting in front of you. Just statistically, you have to have people sitting in front of you that have either DID or OSDD, and to be open to this as actually a very strengths based
Mhm.
like quote unquote problem,
Yeah.
that when given the respect and loving care that it deserves, you can really help your clients really blossom and thrive in a way that they probably never thought that they could. So,
Mhm.
and understand that, yes, it has like many things, right? Folks that are incredibly disabled by it, and then people who are so incredibly high functioning with it. You can't
Mhm.
tell that somebody has DID just by looking at them most of the time.
Yeah. If you were to identify the what the central shift is from when you recognize that somebody has DID, working with that versus working with just an eating disorder, is
Mm,
there, and I know that's probably a
yeah.
complicated question to answer, but what comes to mind?
No, the most beautiful thing that starts to happen is, I mean, there's a little bit of kind of chaos that just naturally happens as parts realize it's okay to come forward and begin talking in therapy, or,
Yeah.
potentially writing emails to their therapist or something to that effect. But the most beautiful thing is you start to see internal communication, cohesion, collaboration, and things start to really work. So things that were not working before, you can have this whole, like the usage of an inner world, for example, as a way of keeping parts safe. You see people begin to navigate things very successfully that they were not able to previously navigate. You see people starting to be able to negotiate internally for what's best for the whole system,
Yeah.
so that you get things like eating disorders much more under control. And you learn to leverage things like, potentially a part that is engaging in eating disorder behaviors because it believes it's like 17, but let's say your client's like 40, right? So the
Yeah.
17-year-old part's trying to look 17. You as a therapist are going to learn a skill set to be able to suggest to that part that it look in a mirror in the inner world and it will see the reflection of itself, which can ease anxiety and allow the entire system to nourish the body. Like you start to be able to very creatively problem solve. It's some of the most fun work that I've ever done, like not to minimize the
Yeah.
pain, but when you start seeing these beautiful parts of someone's system coming forward and trusting you and learning about who they are and what they are, and then you're able to help them understand the ways in which they might be impeding their own goal and how they could accomplish more when they communicate with these other parts that are essentially looking like they're working against each other. It's
Yeah.
such a beautiful thing to see.
Hmm. It's like you're doing relationship work, but within the internal system.
100%.
Yeah.
That's what it's all about. It really is. And some people will fuse, into just one, and other people will have a system of parts probably forever. That's okay.
Yeah. Thank you so much, Monica.
Thank you for having me. It's been such a pleasure.
Yeah.